Okay, everyone. So we are going to talk about digital imaging and PACS, right? So there's a lot of stuff to go over. Let me just talk about what we're going to be talking about. And does that not work? Or maybe not. So I'm already running into some issues here. Oh, there we go. Oh, okay. So we have a lot to talk about. We're going to talk about digital and film screen image receptors, right? So we'll talk a little bit about artifacts and the fact that even though we're in a digital environment, we're still going to get a lot of artifacts, potentially. We'll also talk about spatial resolution, how we can measure spatial resolution. So we'll talk about things like line pairs per centimeter, and we'll talk about putting an actual number on spatial resolution by using a scale known as your MTF. We'll also talk a little bit about the difference between spatial resolution versus contrast resolution, and basically how contrast resolution is almost synonymous with what's known as signal to noise ratio, or signal compared to noise. And I don't know if we'll get to the lookup tables and histograms in part 1 of this video, but maybe in the next one. But we will be able to talk a little bit about PACS very briefly, right? And we'll describe the difference between the Hospital Information System, HIS, the Radiology Information System, RIS, and what DICOM is. A little bit about noise and its influence on contrast resolution, as well as the definition of noise and what noise looks like. All right, let's just kind of get started a little bit. So we start off with some artifacts, and when it comes to digital imaging, it's definitely not an artifact-free system. A lot of the same things that happen in a screen film environment once upon a time can still happen in the digital environment. For instance, if you don't position correctly, the digital system is not going to correct for rotation, right? So improper positioning is still the #1 mistake that people can make. If there's motion, for example, motion shows up as a blur, can't really fix that. A double exposure like you see here. Anyone see what's going on in this image? There's a little baby on top of this person's chest, right? 2 separate images. Can't fix that, right? So double exposures can still happen. If you grab an image receptor that has an image already on it, then you're in trouble. So when in doubt, by the way, erase your CR cassette before using it. I'm not saying you have to do that all the time, but if you suspect something might be there, then erase it. If you use the wrong marker, that can of course happen no matter what your screen film or digital environment might be. And even more so in the digital world, incorrect patient information can occur really easily, right? If you just barcode the wrong page or double click on the wrong name on a work list, then you're going to have information that is incorrect going with the wrong image, and that could just be really deadly, right? And believe it or not, these things happen more often than you would like them to happen. So you have to be really careful out there. So artifacts come in a lot of different variety, right? We just mentioned a few little things, but you can also have improper radiographic technique, although that's harder and harder to happen now, right? The latitude, right, the range of exposures is so wide that it's almost like spin the dial and hit the exposure button, unfortunately, right? So we can take images with techniques that are about 50% lower than what you would normally use on screen film, which is fantastic, except how many people are doing that? Most people are taking images that use a higher exposure than what you would commonly use on screen film. Because you have more latitude and more sort of fixing capability of the system when you go with more radiation versus less. You have about 150% overexposure correction versus underexposure. The other issue, and you'll see in the next slide, is there's a tendency, because of that huge percentage, 3 times as much correction for overexposure, that the tendency is to creep up the exposures versus going lower than you typically can. I know in the screen film world, we used to say, when in doubt, burn it out. Right? Use more radiation than less. But we really shouldn't, or we should try not to do that. There is a whole host of plate artifacts, right? If you get dust inside the CR plate, if there's some kind of string or hair or any, foreign objects that could get in the way of your image and show up, you certainly wouldn't want a radiologist to see some dust or some dirt, misinterpret that as a tumor, have the patient sent for a biopsy, right? And biopsy's done. It's negative, because after all, it was dust. Patient's happy, but they never knew that it wasn't a real issue to begin with. So we got to make sure that doesn't happen. And then there are some plate reader artifacts, because the CR reader itself is a mechanical device, right? There's all sorts of gears in there. The cassette is opening and closing. The screen inside gets pulled out. How many people have been in the lab where you may have seen me get on my knees, open the door, wheel the little thing around to try to get something? So it's very easy for there to get dust and dirt and the other things that happen with mechanical devices in general. This particular image that you see up here is an image with an underexposure, right? So even though you have the potential to lower your exposure, if you go down too low, you're going to get a grainier image. You're going to get noise, right? We call that quantum model, right? We say if you don't have enough quanta, if you didn't have enough photons, because your exposure was too low, then you have not enough data with which the detectors to create an image, right? Because all this digital imaging is based on data, right? Right? The more data that you get in there, the better. So we'll talk a little bit more about data later when we talk about something known as detector quantum efficiency. So let me hold off on that for a second. And in this case, it couldn't be fixed. Right? The system couldn't figure out that it needed to add a lot more density to this image. If things are completely underpenetrated, then it's not going to work. You can't use a finger technique for a chest x-ray and expect it to just work. Right? Anyone that's been out in the field, if you ask them about CR and DR and the ability for it to adjust the technique or change the image after or so post-production, so to speak, or reconstruction, I should say, it's still pretty amazing for them. You guys kind of just see it like, oh, that's typical, right? But it is an amazing tool that has flourished in the last few years. So let's talk about a few more things, right? Photon starvation, we already said, is what happens if you don't use enough photons. You're literally starving the system, the detectors, right? If you don't have enough photons, you don't get enough data. If you don't get enough data, your image resolution goes down. Radiation creep, we said, is this tendency for technologists to use more radiation than less. This is not good, right? When an image came out of a processor and it was dark, what could you say about that image? Or what could you say about that exposure? That it was too much. Let's say you do that same thing in CR and you use twice as much than you could have used. What's the image look like? It looks good, so there's no visual feedback mechanism, right? When things came out of a processor, if it was dark, you knew you overexposed. And you tried diligently to use less exposure on the next time around. And you started to create your techniques so that things would come out of the processor because you couldn't fix things, right? Whatever came out, you had to live with it or repeat it. And if you didn't want to repeat all the time, which is not good for you or the patient, I should have said the patient first, right? Then you start to create a nice select set of techniques. In the digital realm, there's no real impetus to do that. Images just come out good. So, juice it up. That's wrong, of course. We shouldn't do that. The only indicator that we have of a potential overexposure is that exposure index number, right? And what is starting to happen more and more often is the systems are starting to monitor these exposure indices, these EI numbers. And one day, a supervisor may come to you and say, you know what? You've been overexposing patients. And you'll go, really? No. And this may or may not come from a supervisor. It may come from the radiologist. They are slow to focus on the dose being given to patients, but that is starting to turn around as we speak, right? In California, they passed a law where they have dose registries, basically a big database that monitors patients in the entire state. So even if you go to a different hospital, there's one central repository that accumulates a patient's dose. Now, if you go to Nevada, take a little ride to Vegas and go to a hospital there, it's not going to add that dose in to what you may have gotten in California. So this is a state-by-state thing at this point. One day, maybe it'll be nationalized, and you can go anywhere and measure your dose. So people are starting to pay attention to this a little bit. So how do you know if there's something going incorrectly with your tube or your equipment? You have to do what's known as an initial proper calibration. Right? I also altered this PowerPoint. I'll re-put the PowerPoint up along with the video, of course. But there's something known as acceptance testing. Right over here. Acceptance testing is a series of quality assurance tests, QA tests, that are done as soon as you purchase new equipment. Right? So they install a new room. They test it. They benchmark it. They make sure that everything is working correctly and everything is matching the specifications that came with the equipment to begin with. Right? But it's also important not just to test when you first get the equipment. Right? There are some tests that should be done periodically. That might be every day, every month, every year. And usually after some type of repair is done, it has to be tested again. You need to set a baseline so that when you have these measurements and these numbers, that will give you information like, how is the spatial resolution? How is the contrast resolution? What's my signal to noise ratio? What's my MTF that we'll talk about? What's my detector quantum efficiency, my DQE? All these different things that you can test for. If you don't have well-established benchmarks at the beginning, how do you know things are going downhill, a year later? Right? You take an initial set of information with which you can then compare it to later. Right? This is an example, not of a chest x-ray, right? That would look really strange. This is actually a QA phantom. So these phantoms come in lots and lots of different varieties, and you have specialized phantoms for mammography equipment, for special procedures, for CAT scan versus a regular radiography room, etc. So there's a whole world out there of QA. And if you're interested more in QA, you can come back self-referral here for the baccalaureate degree and take my course where we spend several weeks just on QA versus 10 minutes. So here are some issues that can occur in a digital world. This can actually probably occur in screen film, right? The screen can be damaged, whether it's in a CR cassette or whether it's in a conventional cassette. But if you have these little cracks, and sometimes they start on the outside edges and work their way in, they can show up as a sort of lucency or a changed density on the image. And what's a radiologist going to do? Call it a fracture. I told you this story last year. My brother had some x-rays done, and they thought there was a fracture. Casted him, I had some x-rays redone, no fracture, took the cast off. So when in doubt, cast, right? So sometimes an artifact that looks like a fracture ends up being called a fracture, and they cast you. Person never knows. Same thing as the biopsy example I gave before, right? These things happen, and patients never know, right? Roger, yes. Yeah, there's a little line, a faint line going down here, starting about here, going down. And there's this little spot. Whoops. Go back. Sorry about that. And there's this little lucency right here. It's a little dark dash. Right? You probably can't see it there because even on my screen it's small. Right? So these things can be, this is a great example, it could be very subtle. It could be a very subtle thing. Right? Whereas you took the peek at the next slide already, you know, there was something very obvious on that image. Right? So it's important, for example, not to just monitor the X-ray equipment itself, the energizing portion of your X-ray, but it's important to look at your CR cassettes. These things have to be cleaned fairly often and inspected, the same way you have to inspect your lead aprons for cracks. Right? You shouldn't just assume that everything is fine. Now, generally, there's a physicist that does this kind of thing, but there's actually nothing within our license that prohibits us from doing QA and all these tests. Right? If they give you the equipment, the dosimeters, and instructions, right, that could be part of your role as a radiographer. Right? Most hospitals are big enough that they have a separate person that just does that. Right? You have all these IP plate readers, you have all this equipment, right? You can't have, you know, techs doing all different things. But if you're one technologist in a doctor's office with one unit and one or two processors or IP plate readers or a DR system, you can do these things. Right? So these things have to be clean and looked at, and potentially you've probably seen that in our lab, the phosphor in the CR cassette, can it come out? No, it's kind of adhered to the material of the cassette around it. But you've probably seen in some of your institutions that IP plate actually comes out. It's just a sheet, right? Those are probably easier to clean and certainly easier to repair, in that if the cassette, or I should say if the IP plate itself is scratched or not worth replacing, they just get a new one and put it in the cassette. If that happens here, we have to replace the entire apparatus, right? The cassette and the phosphor inside of it. So here's some hair, right? It's pretty obvious, right? It's going from over here and it kind of loops around. And in addition to that, the density can change because of the the static that might be caused. So, anyone see them clean the cassettes? Open up the plates and give them a nice clean? Yeah. Well, I wish it was more of you because they're not doing this enough, right? Remember, this is pretty obvious, but it's the subtle changes and subtle little things that can happen because of, you know, a little dust or some string or hair or whatever it might be that gets in there, right? These things in the IP plate reader, what happens? It's opened up and scanned by a laser. It's at that point where all sorts of dirt can get in there. Dirt, dust, etc. Here's another artifact. Remember, we've talked about this a few times. If you are going to do an ankle, let's say, you shouldn't process it under a head algorithm. Right? If you look at C on the left, now your technique might have been just fine. So the actual exposure might have been good. It's the fact that you chose a different set of instructions and what's known as a different lookup table and histogram, right, that will probably be in video part 2 that we discuss those, where the lookup table is designed to fix your image and give you better contrast and better spatial resolution based on previously established tests. So you have to figure that Fuji and Kodak and Agfa and all the other companies have gone through with phantoms, maybe with some real people, and looked at certain exposure levels and what the proper contrast and mix of densities should be applied to, let's say, an elbow. Then when you take an exposure of your elbow, the pixel values, the brightness levels of all those pixels are compared to what the optimal elbow should look like. And then that image is corrected based on this lookup table. If you choose a skull, but you've actually radiographed an elbow, you're then going to be telling the computer, or the computer will say, I'm going to look at what an optimal skull should look like, and I'm going to try to fix the skull that the technologist took because it doesn't know you actually did an elbow. And then you get unpredictable results. You get an image that might be too light or too dark, and now it's not about the radiation you used, it's about the fact that you chose the wrong algorithm. Now, we have a pretty wide set of algorithms, or maybe narrow, I should say, in the lab, right? How many different algorithms do we have, right? There's a little head button, there's a chest button, like you press on the little person, but in your hospital environment, it's much wider, correct? Right? There's a separate one for hand, and a separate one for wrist, and for forearm, and for elbow. We have one, sort of stick figure up there. You do any of the aforementioned exams, you press just one spot in the lab. So real important to make sure that these are processed correctly. And a lot of times when this comes out on your little monitor, right, each plate reader has its own monitor, right, before it gets sent to PACS. You may or may not be able to reprocess it. It depends, right? People make mistakes, hit the wrong button. You may be able to reprocess that image and fix it before you send it into PACS. We're familiar with PACS, right? That's our big database, right? So, but once it's sent into PACS, it may or may not be as easy to fix that issue. And we certainly don't want a radiologist to see an image that looks like letter C here on the left, because if they do, they just think you maybe underexposed the patient, or they think you don't know what you're doing, right? They should never see this image. Shouldn't even get to them. One of my favorites, the Moire Effect. This occurs when you're utilizing a grid. And what happens here is, this is a CR type of artifact, because this is not going to happen in DR. In CR, let's say you're doing an abdominal view and you use a grid, right? Actual slip-on grid. Then you go to process your image. Inside the IP plate reader, you have your laser that's going to go across each line of your plate, right? And then each line gives you back some light, etc. If the laser going back and forth happens to be parallel to the grid lines that were created during the radiograph of the grid, you can get this Moire effect, right? Where you have these very distinct lines going down the image here. The way to solve this, and it really shouldn't happen too often, is the grid lines should be perpendicular, so a T, to the scanning movement of the laser. So if the laser is going like this, back and forth, left to right, grid lines should be going up and down from floor to ceiling, right, perpendicular. That's how you would avoid this. Now, the reason why I say this doesn't happen too often is, assuming you buy the correct grids, right, that may be recommended with the IP plate reader, and you put it on the cassette correctly, slip it on correctly, and usually you can't screw it up. It's kind of designed to fit one way or it just doesn't work. Then this issue really just shouldn't happen. Right? But it's happened. Here it is. And you can see how that might happen depending on if you're doing tabletop work with a grid. Right? This really shouldn't happen if you're using the bucky, because the bucky's already set up to match with the tube. Right? This is something where you put your cassette into a slip-on grid, and then you just turn that grid crosswise instead of lengthwise, for instance. Speaking of the IP plate reader, we said your laser scans across the image, correct? Not the image, right? The phosphor, line by line. And then what happens with that phosphor? Right, it fluoresces, it gives off light. That light gets read by a photomultiplier, kind of like a vacuum, sucking the light that's being given off from the plate. If there is, let's say, a line of dust that forms on that photomultiplier tube, this is what you can get. A nice, very distinct line. Right? So this is an artifact that's pretty obvious. It means that someone needs to do some PMing, preventative maintenance, on that IP plate reader. Right? Needs to go in there, clean the thing off. Right? If you've ever seen the inside of these things, you know, there's a lot of empty space in there, a lot of ability for dust to get on the optical aspects of the system if it's not cleaned. Who cleans the thing? Who's responsible for that? Usually not us, right? In a hospital environment, usually there's a team of people that do that, right? You have a PACS team or PACS administrators, and some of them work strictly on the computer side, but some of them work on the hardware side, right? Working with doctors to make sure that their images look good, and working with the equipment to make sure that our plate readers are not malfunctioning. This is an interesting, the effect of collimation on your image. And there's a little bit of a, I don't know if the right word is war going on, but in some institutions, and I know a long time ago, when you would shield a patient, how did they know you shielded the patient? Right, if the shield was shown on or displayed on the actual image, then you could claim evidence of shielding, right? It's clear that the shield is there. Now, the way the CR systems and DR systems work is they look and analyze the image, and one of the first things they do is assess the borders of collimation, right? Do I have 4 borders of collimation? Where does it end, right? Because when it goes to the lookup table to assess your image versus the proper or deemed proper image, it's not going to look at the border, right, that white border around the image. It just wants to look and analyze the sort of pixels in question. Now, if you put a shield on, let's say, the bottom of a chest x-ray, you no longer have a well-defined border. So it could throw off the mathematics, right? It could throw off this algorithm. So the question becomes, do I shield? That's not really the question, because you do shield. The question is, do I show evidence of the shielding? Can I collimate out the shield and just tell people, yeah, I shielded? Right? It depends, right? The other issue that can occur is, and this has changed over time, is there used to be a tendency to do multiple views on one cassette. Right? If you're going to do a hand, why do 3 separate 10 by 12s when you can do just one big 1417? Or maybe 2 10 by 12s. Put a PA and a lateral on one, and put the oblique on the other. Now, a lot of analysis in CR is based on the image. When you have two different images, let's say you have a PA hand and a lateral hand, which, right, are two very different attenuations, right, two different thicknesses. How does the computer deal with that? Traditionally, not very well. It's gotten better, especially if you can have two separate rectangles of collimation so that the computer can see I have two separate images. But if your collimation overlaps, it's going to get confused, right? So in many cases, what do you do? How many cassettes do you use for a hand in your departments? 3. Usually the rule to avoid any of these issues is each view gets its own cassette. You know, I hate to use this expression, but back in the day, you used as little film as possible because the more film you use, the more money you spent. Right? So if you can get away by putting multiple views, you know, there was a time where I could put 3 views of the wrist all on a 10 by 12. I have one in this corner, in the left-hand corner, one in the right-hand corner, and one sort of in the middle, all with collimation, and one of them marked. Right, so at least one had a marker. Now you have to do separate cassettes. The only change that I've seen recently is a finger, right? I think they've pretty much created an algorithm that when you put down finger, it's automatically looking for, you know, several views of the finger all on one cassette. Right? The other difference with a finger, though, compared to the hand, is the 3 views for the finger. How much change in thickness is there when you go from here to here to here? You know, not that much compared to a PA hand versus a lateral hand and an oblique in the middle. So if there is a failure of the system to recognize the collimation, you're going to get unpredictable results, right? It might be too bright, too light, or too dark. Question? No? Okay. Okay, here's where it gets fun. We start talking about spatial resolution. So to back up just a little first, when you have an image, you can talk about the overall resolution of that image, and or you can break it down into separate components. And resolution breaks down into 2 major components: spatial resolution and contrast resolution. Spatial resolution is what we call detail in the screen film environment. So spatial resolution is related to the ability to resolve an object. So I've been using this analogy for a few years now. You go to the beach and you pick up some sand. Right? If you can count the individual grains of sand, then you have good spatial resolution. Contrast resolution, on the other hand, is being able to tell that you have differences in densities of the sand. In other words, one is a little bit tan, another one is a little bit beige, different contrasts, right? 2 very different things. The ability to see small objects in close proximity, spatial resolution. The ability to distinguish small changes in density due to slightly different attenuations of the X-ray beam, contrast resolution. And both of these can be measured, right? This is part of that QA process, right? And they should be measured periodically again, because if you're starting to lose spatial resolution for various reasons, and or starting to lose contrast resolution, neither of those things are good to lose, right? Because overall, you don't want your resolution to go down. So there are a lot of things that go into spatial resolution. One of them might be the physical characteristics over here of your equipment. So for instance, if you're utilizing a direct versus an indirect DR, how do you think that might affect your spatial resolution? Which one's better, indirect or direct? Direct. Why would the spatial resolution be better? That's right. You have one less step, so automatically your resolution increases. Right? So we would be going in indirect from X-ray to light to voltage, and in direct we go from X-ray directly to voltages. So you cut out the middleman and you get a better image. Right? It's kind of like, if you go to the art museum and take a picture of the art, you think it's going to be as good as the art? Right? And then let's say someone takes a picture of your picture. You see how you kind of keep going downhill in your resolution when you convert from one to the other. Another aspect are your detectors. Right? We'll talk a little bit more about your detectors. First of all, they have to be at least as large as what you're imaging. So we're talking about flat panel detectors. So for instance, most of them are about 17 by 17, which is actually bigger than a typical 14 by 17 cassette, by 3 inches, right? You say no, Doris? Why? What's different? 14 by 14. In the table? Or the portable one? 14 by 14? Yeah. 17 by 17 would be nice. Gives you a little bit more leeway. Right. So there you can see there's no standard on the size, per se. Unlike the DICOM standard that we'll talk about later. One huge thing, hate to use the word thing, one huge thing that goes into spatial resolution is your pixel and your matrix. So your pixel, or what's known as your pixel or picture element, so pixel stands for picture element, is one of the major factors that determines spatial resolution. And your pixel takes, where is your pixel? Where are all the pixels? They're all in your matrix. Right? So your matrix is like a checkerboard. I'm going to try this. I don't know if it's going to work. Right? And I can't see it. Well, anyway. If you had a checkerboard, like you have up here, our matrix is the number of pixels on the x-axis multiplied by the number of pixels on the y-axis. So here I have a 4 by 4. So how many pixels do I have in my matrix? This is a really small one. It's only 16, 4 times 4. Right? That will give me a certain level of spatial resolution. And in terms of pixel and spatial resolution, the more pixels I have, so number of pixels increasing, the better my spatial resolution will be. The more details I can bring out of the image, the better I might be able to resolve small objects. Right? You can only resolve an object size to the size of your pixel. So you can't resolve something that's smaller than what your pixel can display to begin with. But overall, the more pixels you have, the better your spatial resolution. Now, so let's say I did something like this. I'm going to see if this works. I'm taking my mic off. And I have to say, it's really weird talking with this thing in my ear. Maybe I need both of them on. What happens if I change my matrix okay, without changing my field of view. By the way, the field of view is the border of the matrix. Okay, so provided I don't increase my field of view, which would be like stretching things out, if all I do is increase my matrix size, what happens to the individual pixels? Right, they get smaller, and how many of them are there? Definitely more of them. Right, so we can say in terms of spatial resolution that an increase in matrix size will increase my spatial resolution. And what is your typical matrix size? Well, it varies from modality to modality, right? It varies whether you're talking about CAT scan versus whether you're talking about DR or CR. But typically, we're going to have lots and lots of pixels, over 2,000 per row. So to give you an example, a lot of matrices come in these sizes that I have up on the board. 256 by 256, that means 256 down and 256 across. 512 by 512, 1024, 2048. Anyone see a pattern occurring here? Just keeps doubling. Right? And we multiply those two together, and the numbers get pretty huge. You know, with 2048, you're getting over 1 million pixels. Yes. You won't be able to actually resolve that object. You won't be able to see it. Yeah. And most things are. I mean, if you have 1 million pixels spaced into a 14 by 14 size field of view, then your pixels are tiny. Teeny, teeny, tiny things. And remember, each pixel is the front part of a voxel. So if you were to draw a sugar cube, right, the front of the sugar cube is your pixel. The rest of it going into the wall here, that's your voxel or your volume element. Right? And your voxel also has or is an influence on your spatial resolution. So when you have a smaller voxel, you also have better spatial resolution. And we have to think about voxels in terms of slice thickness. If we have a smaller slice, as you might have in a CAT scan, right, where you can determine how thick you're going to cut your slices, a thinner slice is the same thing as saying a smaller voxel. And if the voxel and the pixel are not one and the same, but intertwined, in that changing the dimension of one will change the overall area of the other, then a smaller voxel gives you a thinner slice and gives you better spatial resolution. Smaller voxels, right, represent thinner slices and give you higher spatial resolution. Another way of saying this is if you reduce the size of your pixel, that in turn will reduce the size of your voxel. Because after all, the area of a cube is based on all of the stems here. If I reduce the size of the pixel in front, the overall area of this cube gets smaller. And in the digital world, we kind of look at that as not being able to put as much signal into the voxel. So in terms of contrast resolution, so we're changing topics just a little. In terms of contrast resolution, when a voxel gets smaller, our contrast resolution will go down. Less signal, not as bright. But our spatial resolution goes up. So this is an issue. One goes up when the other one goes down. So how do you get the best spatial resolution and the best contrast resolution at the same time? You don't. You have to pick one or get something in between. Pretty good spatial resolution and pretty good contrast resolution. Generally speaking, doctors, physicians prefer contrast resolution over spatial resolution, right? Probably better to see that two different objects differ in their contrast because one might be pathology and one might be normal tissue than just being able to count multiple objects. Now, not every matrix is exactly the same, even if it has the same number of pixels. What might that mean? Well, let's say Fuji puts out a 512 by 512 matrix, and so does Kodak. Well, believe it or not, and I'm on this part of the slide here, how the pixels are spaced out. So each one of these little lines that crisscross and intersect each other, is that part of the pixel? Not really. It's the border of a pixel. So you have to imagine that even though you have these tiny, tiny little objects, that there might be a different spacing between them. So they might be laid out in a matrix in a different frequency from one manufacturer to another. Now, when you are sampling all of these, the computer, I should say, is sampling them. You want to sample them as fast as you can, right? And the information that's captured by each pixel, by each voxel, takes the form of a signal. And that signal looks like a waveform, so it has peaks and valleys, like I have here. Do you measure just the peaks? If I draw little dots here, do I measure just the peak? No, that wouldn't be good, right? That's kind of like just half the information. So if I just measure across these, that's not really good. How about if I just measure the center of each valley, right? Each one of these is a sine curve. Right? That good? No, that's just as bad as just measuring only the top alone. Right? So this is not good. It's only half the information again. What really has to happen is you have to measure at least twice per cycle. So this term Nyquist up there says that you have to measure each data point, both crest and trough or valley, at least twice per cycle, right? In order for the best image resolution and for the algorithms to do what they need to do when an image is processed digitally. Right? So that's what Nyquist says. Right? And here's our technical term, right? It is defined as the inverse of twice the pixel spacing. What it really means and what you should remember is that you have to sample at least twice per cycle. Right? That's what I want you to remember. Anyone know what this thing is up here in the corner of the image of the slide? That's one way to test in the center, right? You see all these little lines. That's to look at our spatial resolution because you can measure spatial resolution by line pairs, right? So one way to measure spatial resolution is by line pairs. And a line pair is simply the line itself and the space between the next line. So a line pair is the line and the space between the line. And these are generally measured in a particular unit of distance, right? So you're counting line pairs, let's say per centimeter. So if I have a centimeter here between this end line and the one next, how many lines with the space in between them can I place between those? I mean, you could try this, right? If you wanted to take your pen and pencil, but I can't expect you to get 100 lines. But you can imagine the more lines that you can indicate, the better your spatial resolution. So the more line pairs that you have per centimeter, so that's LP/cm, line pairs per centimeter, the better your spatial resolution would be. So this image in the center left here is looking at the line pairs, and where it starts to blur, when you can no longer make out the space and the line between them, that's when you start to lose spatial resolution. Yes? Okay, so the question is it safe to say that anything that increases spatial resolution will decrease contrast resolution and vice versa? 99% of the time it is. There are some instances where certain things or certain parameters that are changed are good for both. So for example, we said that the images are data driven. If you increase your radiation and you get more photons that are able to be counted by the detectors, you're increasing something known as photon flux. That's good for overall resolution, right? If you increase your flux, I was going to say a joke, but I'm on tape. You mean what the flux? Okay. All right. So if you increase that, that means you're feeding. It's the opposite of photon starvation that we talked about earlier. If you can give more photons to the detectors, then that's going to be a good thing, because that's just adding more data with which the mathematics to work on, right? So that's an example. But I'll give you examples of what you're talking about. 99% of the time, when you change contrast, or whatever you do to increase contrast will decrease spatial resolution. So for example, more pixels, better for spatial resolution, not good for contrast resolution. Yes? So the more line pairs you have per centimeter, that would be indicative of better spatial resolution, right? To show you the way this works, if I have several different objects, okay, between a line pair, they're all going to be ending up within one voxel. So what grayscale, and how do I kind of separate these things out? Theoretically, it doesn't always work perfectly, but we can say if you have more line pairs, in other words, better spatial resolution, you may be able to separate these objects out. So if I have more line pairs, I can theoretically separate these objects so that they can be distinguished from each other. Right? Basically resolved, because the whole object is, can you resolve an object? You know, once an object is too small to be resolved, can you see it? No, right? If it's too small to be resolved, it essentially disappears. So in radiology, you can't see everything, right? At some point, even with CT and all these fancy things, if the object, the tumor, let's say, is at a cellular level, very small, microscopic, you're not going to see it, right? That's where what's known as molecular or nuclear imaging comes in, right? But regular X-ray, regular CT doesn't have the spatial resolution capable. right? You might be able to see 0.3 of a millimeter, a third of a millimeter. That's pretty good, but that's nothing like seeing something at a cellular level, right? Okay. So in terms of matrix, on the left we have more squares, more pixels. We would typically say that the image on the left has a better spatial resolution than the image on the right. Right? But this is all visual, right? We're looking and counting line pairs. There's a numerical way to look at spatial resolution, and that's by utilizing what's known as your modulation transfer function, or MTF. MTF is a better measure because it's numerical, right? You can look at the number and compare the MTF of one piece of equipment, one room, with the MTF of the room next to it. Or if this is a pre-established statistic in the brochure and someone's trying to sell you a CAT scan unit, you can say, what's the MTF of that CT unit compared to the other manufacturer? So how does MTF work? MTF is really a combination that is derived from other tests, other QA tests. So without going into a lot of detail, there's a test known as a point spread function. It gives you a number, right? It looks at points within an image, right? And if the substance that you are analyzing is the same, then every point should be the same within a particular field of view. That's one, point spread function. There's a line spread function, right? Every point that occurs along a linear line, if the tissue type is the same, and in a QA phantom it is, right, because they design it to be that way, you should get the same number. There's an edge response function. There's contrast function. You get separate numbers from these. MTF is nice because it takes all of those separate numbers and puts them together to give you one number that kind of looks at all these other numbers and gives you the general spatial resolution of a particular type of modality, whether you're comparing CT or from one CT scanner to another, or whether you're comparing a direct detector versus CR, for instance, which is what's happening on this graph here. Now, it doesn't necessarily add these numbers and average them. I'm not sure exactly how it's done, but you get this one MTF number, which is a combination of these other tests. And the scale of MTF seems at first like it's a very small scale. It goes from 0 to 1. The difference is that it actually counts by tenths of a point. So it goes 0, 0.1, 0.2, 0.3, up to 1. So if you take a look here, our MTF, which is on the y-axis, goes from 0, 0.2, 0.4, and you can imagine what's in between them, up to 1.0. So if you look at this, direct conversion detectors is leagues away. You know, if this were a race, you know, they're way ahead of all these other competitors down here. So the spatial resolution is much better in direct conversion detectors compared to indirect, compared to computed radiography CR, and compared to film itself, regular old plastic film. If you score a 0 for MTF, basically you have not transferred any of the actual object information to the image information. That's basically a machine that doesn't work. right? You're not transferring any of the information from the object to the screen. Conversely, if you had an MTF of 1, that would be perfect. And radiology is not perfect. Perfect would be you have a little tumor, and like a bad B movie, I rip it out of you and hold it up in the air and look at it in all of its 3 dimensions with my 2 eyes. That would be perfect. And that's what they used to do in a much neater, nicer way when they did exploratory surgery, right? But it's not worth the risk to get better spatial resolution by trying to pull an object out of a patient and risk all sorts of infection, et cetera, et cetera. So we're looking more like somewhere between 0.5, maybe 0.8 MTF, right? Because 1 is impossible, and 0 is just me trying to look at you in the room here and see what's inside you. Basically, there's nothing happening, right? Another quality assurance type of activity is to look at your detectors, right? These are the pieces of equipment that are responsible for capturing photons and converting them to either that light or that electrical signal, right? How well do our detectors function, right? All those little detector elements that are made in our flat panel detector, you can measure how well they perform, how efficient they are. So DQE, detector quantum efficiency, if you kind of look at that and read it backwards, we're measuring the efficiency with which detectors can count quanta. Okay, maybe I didn't go exactly backwards. I kind of skipped around a little bit. But that's what we're doing. How well can we take photons and capture them? So believe it or not every photon that falls into a detector is even recognized. It just kind of doesn't get looked at. Right? And not all detectors, as you can see by this chart up here, have the same level of efficiency or the same DQE. So again, DQE goes from 0 all the way up to 1. And 1 would be 100%. That means every photon that falls into a detector, all billions of them, gets counted. That doesn't happen. The reality is, in a CR system, you're only counting between 15 and 25%. So what happens to the other 75? Nada. Nothing. Just doesn't get counted. Remember, again, data-driven. So that means you don't end up making these measurements which contribute to your pool of data. DR is up above 40%. Let's say it's 40 to 50%. So we're literally counting, almost twice as much. So that's why your image is ultimately going to be much better, because your detector quantum efficiency in a direct DR system is better than an indirect CR system. Take a look. One is CR, one is DR. This is a magnified view of a metacarpal phalangeal joint. Which one do you think is blurrier? Because that's how you assess spatial resolution. Yeah, B I think is a little bit blurry. Right? This is is much sharper on the left side here. Whoops. Sorry.
So what about film?
Film, some people will argue that film still has pretty good spatial resolution, right? But, if we go back, and by the way, these charts are taken from some of the worksheets that I've given you on Blackboard in that extra worksheets section. So you might want to take a look at those prior to our exam. But here's a graph, and we have film screen, this black line over here. Okay. with everything having better DQE above it. Now, when the digital modalities first came out, film still ruled. But the digital modalities have caught up. I mean, just look at your digital cameras now compared to, I think the very first one I had was 1.5 megapixel. Was my first digital camera, right? So as technology gets better, so does the DQE and the overall spatial resolution. But it's dependent on having enough quanta, right? You can't take and use enough radiation that might penetrate a finger and try to get away and use that same technique on a KUB, right? You're going to get quanta model. If you don't have enough quanta, photon starvation, if the detectors don't have enough information to tabulate and count because you didn't use enough technique, you get a grainy image. This is noise, right? So this grainy image is what we call noise in an image. And I'll kind of start to wrap things up here. There's a dilemma that we have in our field. Right? If you want to get rid of noise, the best way to reduce noise down, would be to increase radiation, dose up. So while that's good for the image, is that very good for our patients? No. So the dilemma is, how much noise can we live with and still make a diagnosis? Because the noisier the image that we can still make a diagnosis off of, the less radiation that we needed to give to the patient. Right? So there's always this kind of signal, which is a brightness, compared to noise. So not only do noisy images get grainier, but they also get darker because their signal to noise ratio goes down. In other words, you start getting more noise and not enough signal. Right? This in particular is quantum noise, right? So this is noise that's based on not having enough photons. In the digital world, you have a few different kinds of noise, and this is where I'll kind of wrap things up for real, is you have statistical noise, which is the type of noise based on the mathematical algorithms that you're utilizing. Right? So as the computer scientists create better and better reconstruction algorithms, then we can get images that remove more noise than in the past. And if that's the case, you could use less radiation to begin with. Right? Noise reduction software. Right? Kind of like Photoshop for X-ray. There is mechanical noise. Mechanical noise is the type of noise that's inherent in anything that is mechanical, like our CR. So just based on mechanical noise alone, you're going to get a better image in DR because there's less moving parts. Right? There's too much stuff going on. Lasers going back and forth. Right? You don't have all of that in a direct DR flat panel detector system, for example. So quantum noise, statistical noise, mechanical noise, all noise is bad, right? So anything that we can do to reduce noise will increase contrast. So noise is directly linked with contrast. Noise down, contrast up. Okay, so this is the end of part 1. So part 2 is coming to my YouTube channel. This whole presentation is subject to exam.